Good morning, everyone. In the interest of time, we're going to get started with the next session. And this is on follow-up after focal therapy. There's been a slight change in the program. Our first speaker, Dr. Lebashi, is not able to be with us. So in his place, we have Dr. Tan, who's going to be speaking on consensus guidelines.
Dr. Tan is Assistant Professor of Urology in New York University Langone Health in New York City. He did his residency in Rush University Medical Center and followed by a fellowship in Duke University. So his research interests focus on malignancy of GU system, especially on prostate cancer diagnosis, focal therapy for prostate cancer, and also robotic-assisted surgery. Wei Pin, please.
Thank you. Tough act to follow after my boss, but I'm going to step in for Amir Lebashi. He sends his apologies. He had to go back to Los Angeles. So his topic that he was tasked with was the consensus guideline for surveillance after focal therapy. These are all his disclosures. I have no financial disclosures. Essentially, the focal therapy is actually not listed in any of the guidelines so far. If you look at the EAU and the AUA guidelines, essentially it says that if you're performing focal therapy, it should be on a trial basis so that these patients are followed appropriately. There are many other reasons as well on why it hasn't been adopted into the mainstream treatment paradigm. And a lot of it's because there isn't much long-term survival data. There are multiple platforms pertaining to different ablative technology. And it's really tough to compare all of them because each of them have, its own benefits and specific uses. In order to advance the field of focal therapy, when there isn't much evidence, every year the Focal Therapy Society conducts a consensus, a Delphi consensus, basically to address topics that there isn't much in the literature about. So essentially, usually, this is an international multidisciplinary consensus panel, which the Focal Therapy Society conducts every year to address questions such as this. If you're not a member of the Focal Therapy Society, please join us. It's focaltherapy.org. Typically, our design will be a thorough review of the literature pertaining to controversial topics in the field of focal therapy. We then develop a set of questions. A lot of these questions are then actually sent out to participants who are experts in the field of focal therapy and prostate cancer as a whole. So for this year, this was a consensus that was done in 2018 to 2019. Essentially, we conduct this consensus statement via SurveyMonkey. Typically, we conduct a Delphi consensus where we send out 3 sets of questionnaires. So essentially, the participants are sent up a set of questions and they vote. We usually, 80% is regarded as consensus. So essentially, after the first round, the questions that has met consensus be omitted, and we will send participants the second and third round to essentially try to develop consensus. So this is a methodology where participants are actually allowed to see the percentage of people voting in a specific question to ultimately try to develop consensus over a period of 3 consecutive rounds. In the final round, we usually meet in person or over Zoom these days to try and finalize the questions that we were not able to achieve consensus on. So for this was predominantly a urology and radiology group. Since then, we've also gotten many of our other disciplines, such as radiation oncology, to participate as well. Essentially, it consists of urologists and radiologists that perform all different forms of focal therapy. So you can see on the right column that participants perform HIFU, laser ablation, cryoablation, IRE, radiotherapy, PDT, and whatnot. Essentially every form of energy out there. For this consensus, the 4 hot topics were PSA, functional outcomes, biopsy, and imaging. Remember, this consensus was done about 5 years ago, so I think most institutions doing large volume of focal therapy has tweaked it a little bit, but the general gist of this remains consistent. Essentially, in terms of the PSA, The panel agreed that PSA is the preferred non-imaging biomarker in the follow-up of patients following focal therapy. Essentially, the panel agreed that for the first year, PSA should be obtained every 3 months or so, and subsequently from year 2 to 5, it's done every 6 months. At our institution at NYU, we do it at month 3, 6, and then every 6 months to 5 years, but the general gist of it is pretty similar. In terms of imaging, MRI is the preferred imaging modality to follow patients following this. I see that the next speaker will be discussing the way we use MRI to ultimately follow patients to determine if they recur. But this is the preferred method, and the panel agreed that early contrast enhancement in the treated lesion is suggestive of failure. Since then, there are multiple groups around the world that has came up with various definitions to determine the likelihood of failure based on how much enhances in the treated lesion, which we will probably discuss later on. But yes, the MRI is the preferred way of following patients to determine if they had any failure. In terms of imaging, the panel agreed that post-operative imaging should be obtained within 6 months after focal therapy. Subsequently, it should be done every year. Every institution has a slightly different variation on this. At NYU, we do it at month 6, year 2, and then year 3.5 and year 5. This is a scheduled routine MRI, meaning if the patient's PSA went up and you had a clinical suspicion, you could always obtain an MRI to make sure that there isn't recurrence before that. In terms of a biopsy, yes, there's always a debate on whether we do a biopsy after focal therapy. I think there are many reasons on why we should do a biopsy after focal therapy. For the purpose of this consensus, the panel agreed that a patient should undergo an MRI targeted biopsy and a systematic biopsy. The consensus there was 86%. One could also perform a risk-adapted approach on whether to do a biopsy or whatnot. At NYU, we used to do a biopsy at month 6 and year 2 and year 5, but because of our good outcome, as Dr. Lepore presented, we're trying to scale back in terms of how aggressive we are about a biopsy. So if the MRI look good, occasionally, we try and hold off on a biopsy until a subsequent time. But for people who are studying a focal therapy program, I do think that you have to evaluate your outcomes, because failure of the focal therapy is not just pertaining to how the procedure went and whatnot. It's actually a team effort, because it comes down to the radiologist, the pathologist, and there's a lot of factors that go into that account. So you have to determine how successful your treatment is before you can decide to omit a biopsy, and that's the basis behind why the panel essentially had a consensus on that we should do a biopsy following focal therapy. In terms of a systematic biopsy, that's a highly contentious topic before or after focal therapy. But for the purpose of this, the panel agreed that it is important to perform a systematic biopsy between month 6 and 12 after focal therapy. In terms of functional outcome, panel agreed that that's obviously very important. The first time, so you should always have a baseline functional outcome, but following focal therapy, the next time you assess it should be between month 3 and month 6. Looking at a lot of cryoablation and HIFU data, we know that immediately after focal therapy, if you treated the nerve, there will be a hit in terms of your erectile function, but many a times that recovers, so you do not know the new baseline until you're about a year to 2 years out following cryoablation, and that is probably the same for any form of focal therapy if the nerve has been treated. And thank you.
Thank you so much. I'm going to invite the next speaker, Dr. Law. Dr. Law is a senior consultant radiologist at Singapore General Hospital and the deputy director of body imaging in the hospital. She has completed advanced specialist training in diagnostic radiology in 2007 and has a special interest in prostate imaging in particular. She has been awarded Ministry of Health Fellowship in 2008 and in 2014. and has also trained with Dr. Peter Choyke and with Dr. Baris Turkby at the NIH. I've personally had the fortune of interacting with Dr. Law in the last 2 days, and I've been thoroughly impressed by the depth of knowledge in prostate MR and in focal therapy. So Dr. Law.
Thank you, Sankit, for the introduction. Okay, so this morning, thank you for the invitation to speak on this very technical topic on PIFAP, PRECISE, PIQUAL, and the real-life applications. So PIRATS 2.1 has been pivotal and firmly established in standardizing MRI for prostate cancer evaluation. And we know that through all this level 1 evidence of all these large multi-center clinical trials, this MR-directed pathway is definitely superior compared to what we do previously. So we know image quality is crucial in any image MRI-guided pathway, but there is actually no standard approach to assess image quality on the current PIRATS guidelines. And there is also evolution of MRI beyond initial diagnosis to active surveillance, local recurrence, after treatment, etc. So all these specialized new scoring systems, PRECISE, PIQUAL, and PIFAP, are actually developed by experts to define, for certain defined clinical scenarios, as well as to meet the unmet needs that PIRATS have not addressed. So what is PRECISE? PRECISE stands for Prostate Cancer Radiological Estimation of Change in Sequential Evaluation. It is a mouthful, so in short, PRECISE is used in an active surveillance cohort. And it is the most mature of the 3 scoring systems that we're going to talk about this morning, using a 5-point scale to assess whether the patient has progression on MRI. And there are many retrospective validations in the literature to show us that the stability on MRI in an active surveillance cohort is a very good predictor of clinical stability. And we may be able to avoid rebiopsy in this cohort if the MRI is stable. However, this expert consensus are always formed by experts in academic centers. So there's a question of this can be generalized to the community practice. So PRECISE, while it has a 5-point scale, it can be divided into 2 big groups, 1 to 3, which means radiological stability. And this has been shown in many papers that more than 95% of these patients are actually clinically stable. And the second group is PRECISE 4 to 5, which implies progression radiologically. And in this group, above 50%, in fact, above 60% of them demonstrate clinical progression, which may either need active treatment or rebiopsy. So it has to be noted that PRECISE criteria has been shown in many published literature that there is a very high NPV, but a moderate PPV, which means that if it is negative for radiological progression, then the patient can pretty much safely be followed up without a need for rebiopsy if every other parameter is also stable. But if there is radiological progression, then perhaps you should reconsider whether you still want to continue watching without intervening, or you want to do a biopsy, or the patient may need active treatment. So this is one of our patients, 65-year-old male patient with grade group 1 cancer on active surveillance. So we can all see this PIRATS 4 lesion at the right anterior transition zone in an MRI in 2022. So PSA was increasing, and we did a new set of MRI 2 years later, and this lesion anteriorly at the right side obviously has grown in size slightly and with more restricted diffusion. And if you look at the prostatic capsule, you may see that, there could be a little breach of the capsule here, so which means that there could be a chance that there is increased risk of extraprostatic extension. And the PSA is also increasing. So because of this, if there is a risk of extraprostatic extension, then this becomes a PRECISE 5. And this patient refused any more biopsy, so he was advised to go for radiotherapy. Another patient with slightly elevated PSA with grade group 1 on active surveillance, there is a mass at the anterior transition zone, which is a PIRATS 4 lesion. PSA increased, and when we repeated the MRI 2 years later, you can see that the mass has increased in size, and this is a PRECISE 4. When we rebiopsy this patient has significant grade group 3+4 cancer at the targeted area, and he then underwent focal cryoablation because there's no cancer elsewhere, and it's nicely ablated with retraction of the capsule at the post 1 year and a 3-year post-focal, and the PSA remains very nice and flat after focal. So this is a very good outcome from our focal cryoablation clinical trial study. So what about PIFAP? PIFAP means for prostate imaging after focal ablation. So for a long time, there was actually no standard scoring system to assess an MRI post-focal. So this scoring system is a proposal by the UCL group using a 3-point score where the dominant sequence is the DCE and it is only to assess the ablation site. So in summary, PIFAP 1 and 2 means that the patient can be surveyed with PSA and MRI without a need for biopsy. But if there is a PIFAP 3 finding, which is suspicious for recurrence, then this patient should get a biopsy, and this is proposed in this, and this requires validation. So validation has been done this year because this proposal was just done last year. And the first validation was done by my good friend Dr. Baris Turkby and myself. We validated a group of 40 patients using this PIFAP score. And our results are pretty good. We have very high sensitivity, moderate specificity, and very high NPV with moderate inter-reader agreement. And this is a very novel scoring system. So I think our results are pretty respectable. And in a second group, in the Switzerland group, they perform another validation, this time on HIFU cohort, about similar sample size. These two radiologists, they have slightly lower experience. Reader 1 has only 4 years and Reader 2 has 1 year of experience. So if you look at their results, the sensitivity is significantly lower than Baris and myself, who has slightly more experience in a post-focal MRI. But they are traded off with very high specificity and also very high NPV. And this group has near perfect agreement for using the PIFAP scoring system. So this is our patient with a small lesion at the right anterior peripheral zone, which is a PIREX 4 lesion, and a smaller lesion here at the left anterior peripheral zone, but this is near the apex, another PIREX 4 lesion. So this patient had targeted biopsy, which only yielded a Gleason 8 cancer at the right side. And the left apex peripheral zone, I believe that sampling error, it was negative, and there was high-grade PIN at multiple cores. So this patient was one of our earlier patients, and he then underwent right anterolateral ablation. And 1 year post-focal, obviously the PSA didn't respond much. In fact, it might be slightly higher than the pre-focal PSA. So when we look at the 1 year post-focal MRI, the ablation site has scarred and there is fibrosis with no enhancement, but posterior to the ablation site, you can see this lesion here, which has suspicious MRI findings, and this is given a PIFAP score of 3, DCE and DWI are positive. So this is incomplete ablation or residual tumor of the original ablated site. As for the left anterior peripheral zone apex lesion, which was negative on initial biopsy, it has grown larger, and it remains a PIREX 4 lesion, but this time round, we repeat a targeted biopsy of both this lesion, and it shows multiple cause of significant Gleason 4 and Gleason 7 cancer, and this patient had radical prostatectomy 1 year post-focal. So the other lesion at the left is given a PIREX score of 4 because it is not a focally treated lesion. So to make matters more complex, there's a new scoring system for post-focal ablation MRI, and this is called the Target, which is an international consensus just published 2 months ago in May 2024. And based on this international consensus, they recommend that post-focal MRI be performed 12 months after the focal therapy, which is slightly different from the Delphi consensus, which was published earlier. And this time around, they use a 5-point scale also to evaluate the ablation site. So the next question is, which is better, PIFAP or Target, since both are equally new? So to address this, Baris and myself did another validation cohort on the same group of patients that we used Target, and we wanted to see if there's any change in the grading when we use the two systems. So based on this two graph, you can see that both of us actually pretty much perform the same way, regardless of which grading system we use. And our inter-reader agreement for Target is also moderate at 0.57. And however, when we correlate PIFAP and Target for each reader, there is moderate and substantial agreement using these two scores. In fact, our accuracy is slightly higher using the Target score, which is the blue line, compared to PIFAP score. And so this shows that Target using a 5-point scale may be a scale that a radiologist is more familiar with, because PIREX also uses a 5-point scale. And it has potentially to be more accurate and a more balanced approach compared to PIFAP. So this is unpublished data, but this manuscript is currently under review with academic radiology, and Baris has kindly allowed me to show the results. So for PIQUAL stands for prostate imaging quality. So PIREX is only as accurate as the quality of MRI as we know, And PyQual has recently been upgraded upgraded to PyRET's version 2, where they changed an original 5-point scale to a 3-point scale, and now they incorporate biparametric as well as multiparametric MRI in quality assessment. So in summary, the PyQual assessment questionnaire is pretty complex, but in practice, the minimum criteria that a set of MRI is suitable for evaluation to assess for cancer is a PyQual score of 2. And this is especially critical in a post-focal surveillance because there's so much treatment changes that you really need super high quality MRI in order to detect recurrent cancer, either at the ablation site or elsewhere in the gland. So hip implant, in patients with hip implant, it's a challenge to get good quality MRI, and it tends to affect DWI greater than T2 weighted and DCE. This is one of our patients with a right side hip implant. If you look at the DWI, it's completely distorted and not interpretable, but there is a suspicious lesion at the right side anterior peripheral zone, and it is shown to enhance on DCE. So with DCE, it is a very good safety net in patients in whom the DWI sequences are suboptimal, and that's actually very common in general practice and in real life. So DCE, while it is expensive and prolongs a time, and there are people who are trying to shy away from it, sometimes can save the day in certain instances. So this is a PyRET's 5 mass, and this patient had biopsy and is grade group 4 cancer with extraprostatic extension, even on the biopsy specimen. So this is a patient of ours. The first set of MRI done for high PSA was suboptimal because if you look at the rectum, there's a lot of gas, there's a lot of rectal peristalsis, the prostate outline is blurred, the definition between peripheral and transition zone is blurred, and the radiologist reporting it thought that there was the lesion at the left, but he wasn't sure, he thought there was some inflammation, but slightly abnormal DWI signal, and DCE was negative, but he wasn't confident, so he graded this as a PyRET's 3 lesion. PyRET's 3 is a melting pot for you to sit on the fence when you're not sure. And this patient that opted for surveillance because we think that this is a low-risk PyRET's 3 lesion. So MRI performed 2 years later because the PSA continued to increase. It's a much better quality with a flat rectum, and there is no significant rectal peristalsis. And this is a PyQual 3 images when almost every sequence is diagnostic. And the right peripheral zone lesion is a lot better seen, and I can confidently say this is a PyRET's 4 lesion with restricted diffusion and positive enhancement. And in addition, there are many more lesions at the right anterior transition zone, which actually could be seen, most likely was already there in the previous, but because of the motion, you can't actually confidently diagnose it. And these are all PyRET's 4 and 5 masses, which we biopsy it, and they were all grade group 2 and 3 cancer. So in conclusion, PyRET's is transformative and extremely valuable for prostate cancer detection and diagnosis. All this new standardized scoring system in PRECISE, PyQual, and PyFab aim to standardize reporting in different clinical scenarios and to address the unmet clinical needs of PyRET's. And it helps us establish a universal language to facilitate communication between healthcare providers. For example, in a busy clinic, if you have an active surveillance patient, I can tell you there are 4 lesions, some are big, some are small, some are stable, some are what, but if I can give you a precise score of overall, it's 3, then you can be quite confident that this actually implies radiological stability, and this patient may not need active intervention if everything else is stable. So it acts as a very useful platform for international collaboration and research as well. And research and validation will then be instrumental in refining the roles of these scoring systems and their use in clinical practice. And finally, thank you for your attention. And as this meeting is coming to an end, please spend some time exploring Singapore. This is a beautiful picture of the Marina Bay area captured by my classmate who is a primary physician in the Heartlands. So thank you very much.
Thank you, Dr. Law. We'll keep the questions for the end. We have 15 minutes for panel discussion. I'm going to now invite our next speaker, Dr. Tain Naw. Dr. Naw read medicine at Royal Free and University College London Medical School before completing histopathology training in London. She was appointed consultant in histopathology at the Imperial College Healthcare NHS Trust in 2011, based at St. Mary's and Charing Cross campuses. Currently, she's appointed as senior consultant in histopathology at the Singapore General Hospital. Dr. Naw.
Thank you for inviting me to speak today at Eurofair. So my topics are interpreting biopsies after focal therapy. So just quick run through. So there are 4 categories of histology that we document when we report prostate biopsy. The first 2 in black, acinar and ductal, are predominantly account for 90% of the lesions. On the report, we include the Gleason score, no tertiary grade in the core biopsy. We assign the Gleason score to individual sites, the percentage, the length, and the grade group. We also document the presence of or absence of extraprostatic extension. That usually is present. We exclude the patient from focal therapy. Fat is a good indicator. The skeletal muscle is a softer sign, but we no longer use it as it may be represent biopsy from the apex and anterior aspect of the prostate gland. Ganglia is another soft sign as well. Perineural lymphovascular invasion, intraductal carcinoma, and high-grade PIN is also has to be documented as well. So we have an increasingly common scenario where we take a lot of biopsies and we find small lesions, like the one on the top and the one on the bottom. There are 2 lesions which are a bit suspicious. So there's a higher focus of the lower lesion. It has the architectural and cytological atypia. However, there are very few glands. Thankfully, we have immunohistochemistry that we routinely perform now. And it shows that the top cluster has focal staining, whereas the bottom has no staining. So in this scenario, we call it ASAP, which is an atypical small acinar proliferation. Usually, we classify that when it's a small size, lack of atypia, significant atypia, inflammation, atrophy, or it's adjacent to high-grade PIN, or the H&E immuno is not performing well. This is the other thing that we also document in our specimens. Cribriform grade 4 is associated with poor prognosis. So on the left is the H&E. On the right, we routinely do immunohistochemistry to demonstrate the absence of the basal layer. Intraductal carcinoma, this is also associated with higher grade cancers. It looks like a high-grade PIN on low power. However, you can see that the basal layer, unlike the high-grade PIN, shows a more continuous layer, and the nuclear features are more pleomorphic, and they have expansile features. So that's intraductal carcinoma. The one on the left is an NKX marker, it's a prostate marker, because the patient was known to have colorectal cancer, so we had to confirm that it's actually prostate origin. So talking about treatment, so we have 3 main broad categories. The first one is radiation, the second one is hormonal treatment, and the last one is cryotherapy. The first 2 usually causes significant changes to the, especially in the radiation, will be the nuclear features will be quite marked. And the second one, which is the hormonal treatment, it usually causes marked atrophy, and it tends to cause an increase in upstaging of the Gleason scoring. So as a result, we don't routinely Gleason score the first 2. As for focal cryotherapy, we still routinely do it. So I'll show you a few cases of what we have. So the first patient is a 65-year-old who initially presented a PSA of 6, Gleason 3+3 active surveillance in 2019, and a repeat MRI showed PRATs 5, and a repeat biopsy 2021 had 43 cores. So he underwent cryotherapy in March 2021, and a follow-up biopsy 1 year later. 32 cores were taken, and it was negative for malignancy. As PSA was done in April 23 as well as 24, and it remains less than 1. So let me show you what we found. So this is quite a nice picture of the findings we find. So on the right side is the area ablation. It's completely hyalinized. On the left is the adjacent flanking prostatic glands. So at higher power, you can see there is revascularization, there's hyalinization, and very few glands. You can also find dystrophic calcification on the top, and pigment-laden macrophages, inflammation adjacent to it. Sometimes you notice that a few atrophic glands beside the ablation area. In addition, you also might find basal cell hyperplasia post-cryotherapy. And the top picture shows the basal cell hyperplasia. The bottom highlights the basal layer, which is quite prominent. Patient 2 is a 61-year-old who had initial PSA of 4.74. His MRI showed PREDS 4, and then 2016, he had the Gleason 3+3 in 1 of 21 cores. This is his original biopsy, 3+3. And then his PSA subsequently raised, but he declined biopsy, and then a repeat MRI showed increase in size of index lesion. So the patient decided, yes, I will go and have the biopsy again. And 2021, there were 4+3 in 2 cores, 3+4 in 4 cores, and then he underwent focal therapy in May 21. His PSA was 1.5. And then they had total number of cores in 2022 was 39 cores, and 3+3 in 4 cores, and 3+4 in 2 cores. So let me show you. So this was the infield recurrence. This was 3+4. And then he had an outfield recurrence, which was also 3+4. So I think he decided that he will carry on with focal therapy. So the learning points is the importance of pre-op staging, adequate sampling and disease localization, and the presence of multiple focal lesions outside the treated lesion. The last patient is a 72-year-old. He presented with a PSA of 8.96 from health screening. His MRI was PREDS 4, and his first biopsy in March 2022, he had 2 cores of 3+4 in 38 cores. So this is initial core biopsy was in the left anterior aspect. So this 3+4, and then the immunohistochemistry was performed. So he underwent focal therapy in June 2022, and his PSA decreased to 3.2. PSA subsequently raised to 4.9 and 6.2. However, he declined biopsy, but he decided that he had enough of focal, and he underwent radical prostatectomy. So this is our whole mount post-cryotherapy. And you can see in the top left here, this is the area of the ablation site. So I'll show you on higher power. So this is at times 0.5. This is the ablation site. It's completely hyalinized, with a rim of atrophic glands surrounding it. And this is the area where you can see the pigment-laden macrophages lining in the middle with the ablation site on the right side. The left side was the background prostatic parenchyma. And to account for his raise in PSA, we noticed that he had quite a lot of adjacent inflammation, which could possibly account for the raise in the PSA. So often a pre-cryo biopsy, we often have 30 cores. They're usually a combination of MPRI, identified lesions, and general saturation biopsies. If there are more than 5 cores that are devoid of glands, we usually highlight to the urologist that there might be some undersampling of lesion. It's also useful to document presence of urothelium, especially if the tumor is near an area of urothelium. Post-cryotherapy, we also have at least 30 cores. So it's usually a combination of ablated and non-ablated areas. The ablated areas, you can assess for the hyalinization, fibrosis, degree of gland atrophy, and presence or absence of tumor. So if there are more than 5 cores that devoid outside ablation area, we also wonder about undersampling. So the challenges are saturation biopsies are usually about 30 to 50 cores versus our usual TRES, which takes a lot longer to report. We use a lot of immunohistochemistry because we biopsy a lot, so you'll find a lot of incidental lesions. There's also inter-observer, intra-observer variability, and because of the changes from time to time, Gleason grading and scoring, this also has impact on our reporting. Thank you.
Thank you, Dr. No. That was a very thorough kind of, description. I'll open the house to questions at this time. And if not, maybe I can start with the first question, maybe both for radiology and pathology. How soon is soon enough? Now, if you look at different guidelines, some say 6 months, within first 6 months do the first MRI, some say after 12 months. Is it easy to interpret and diagnose if there is residual disease on MR and on pathology? Like, how soon is soon enough?
Okay, thank you, Sangeet, for the question. So previously, the Delphi consensus used to say 6 months. So, but we have always done a 12 months post-focal. And I like 12 months because that is when things tend to stabilize, inflammation decreases. And it's not just the ablation site, the adjacent gland that's not treated as well, often has collateral effect from all the ablation. So far from my experience, which actually we hardly do, we might have do 1 or 2 6 to 7 months when the PSA suddenly increase, but most of them are 1 year. And 1 year when things stabilizes, it gives me a lot more confidence when I see some enhancement that I am actually pretty confident that we need to look at this area on biopsy. Whereas if it enhances at the 6 months, I'm not sure if that's actually post-ablation inflammation. And so for those cases that we biopsy at 6 months when we have done them, it has come out negative many times. So I'm glad that the new target consensus now says 12 months, in line with what we have been doing all this while.
Thank you. And for pathology, is it difficult to interpret samples if it's...
I think if it's under 6 months, I think it would be very difficult with the hyalinization, necrosis. So I think most of our specimens are 1 year. So I think because it doesn't impact on the tumor, so in the sense that there's no changes in the scoring, so we can still continue to score. So, yeah.
Thank you. I think Dr. Lip has a...
Three excellent presentations. You see, the performance of MRI is really going to depend on the quality of your ablation, right? So MRI was very good at detecting the original cancer, and if you do inadequate focal therapy, it'll also be good at picking up the recurrence. And I think that's where some of these Delphi recommendations, not one of them are evidence-based. It's just a lot of people getting together, and you get exhausted answering the survey that you just want it to be done. And so all those recommendations are really not evidence-based, whatsoever. And I think when we make these blanket, look, I know there's some focal therapy HIFU studies that'll have 40% disease recurrence. Well, MRI will probably perform very well there. In our series, where we actually try to treat the cancer, it doesn't perform very well because we just don't have a lot of recurrences. And the question I have really comes back to the FAB validation. I was shocked that that paper got published initially without any data. It's just, well, we sort of think this is important. And then I guess some of the validation studies are coming out. But when we looked at our original series and we had 6 cases of contrast enhancement, only 1 of them was positive. So we stopped doing biopsies on contrast enhancement. Now we have a paper out, which again, I don't know where it is in the review, but we actually had 12 cases of contrast enhancement within a year. And we did the natural history of those at 2 years because we followed all of them, and it went away in every single patient. And the only patient that was positive was a patient where it resolved because we did routine biopsy. So I'm not convinced that contrast enhancement early on means anything other than granulation tissue if you're doing reliable ablation. And many times, if you have the contrast enhancement together with the ADC findings, well, I think that's another story. And I think that, again, probably the MRI, even within the first year, if you're doing good ablation, probably. But again, I think the thing is that your performance of MRI is going to depend upon the performance of your ablation.
Completely agree with you, Dr. Lepore. If it's a great ablation and I see nothing, then that's not a very satisfying MRI to read. Whereas if it's not so well done and I see something, then that's a positive MRI, and I'm quite happy reading that. So I completely agree with you. And I completely agree with you that I have seen enhancement disappears after 3 years, 5 years follow-up and an initial biopsy, because it's a mandatory biopsy cohort, so we biopsy all of them, and they were negative, so they have gone away. So when the enhancement is together with DWI finding, then that's very confident. Yep, I agree with you there. Thank you.
I just wanted to also weigh in on that point, because we did these studies in kidney, and we followed these patients along because of enhancement, and we see that after 8, 9 months, the enhancement disappears. The concern is a lot with the IR people, they tend to biopsy on the early side, because if they need a reablation for kidney, they do it. But for me, I'm okay waiting 12 months for some of those final changes to take place. My concern is, though, going forward, as we start taking on more aggressive cancers, I think a lot of the physicians feel like we need to get earlier biopsies because we may need to rescue. So then we go from 12 months to 6 months for decision making. And I'm not so sure that's the best thing for the patient if there's a lot of residual effect and inflammation around.
Yeah, I agree with you that actually in the area of focal therapy, honestly, time will tell. Time will tell, and we just have to sit tight and watch and keep watching the same area, and hopefully it gets better with time.
I think this is an opportunity to also discuss the biomarker response to focal therapy, because my impression is, depending on the location of the lesion and the location of the ablation, you get a variable amount of PSA response. And it could be the anterior fibromuscular stroma does not respond the same as the peripheral zone in terms of PSA production. But that can lead to miscalculations in the post-op and for-cause biopsy being too early. So we have Dr. Lepore here. Perhaps we'd like to get some opinions about, are there zonal differences in PSA production? And will those zonal differences play out as we treat in different areas of the prostate?
I'll just make a quick comment. When I see a patient with an elevated PSA, really high, 10, 20, and it's a transition zone tumor, I feel very confident in that patient being a good candidate for. I see that in a peripheral zone, and you're absolutely right. The amount of production of PSA per gram of tissue is much higher in the transition zone, and those are cases you feel so good when they come in with a PSA of 13, and 3 months it's 1 or less. And I do believe, and in fact, I would challenge anybody. The utility of PSA, we get PSA all the time. In active surveillance, is there one guideline that tells you what to do about that PSA? Absolutely not. And when we look at focal therapy and we look at our recurrences, we can't find any PSA predictor of recurrence, because PSA, I think, generally is not a very reliable marker post-ablation, because it isn't very reliable in active surveillance to begin with, right?
I had the pleasure of reviewing Caroline Moore's PIFAB paper, and I'm pretty sure I selected reject. Not sure how it got published. Anyway, pertaining to Dr. Lepore's point, I do think that the PSA following ablation may not be a good indicator to determine success following focal therapy. But unlike pre-biopsy patients, PSA velocity probably becomes a lot more important following focal therapy. I also think that there are a few things that's really important, especially for people who haven't done many focal therapy cases, because a lot of times once you've ablated a specific lesion or half the prostate, for example, the urethra usually shifts. So it's no longer going to be in the midline. It's going to distinctly shift due to, fibrosis and whatnot. And to determine which part of the prostate is the left lobe and right lobe can become challenging, especially if you're doing transrectal biopsy, because now you're in a left lateral decubitus position. So sometimes you should consider putting maybe a catheter in there if there's some concern that you cannot determine which side is which.
Yeah, hi, Michael Chow. Just a question for Dr. Tan and possibly Dr. Law as well. What do you think about the use of a PET scan for follow-up for focal therapy patients? The reason why I've asked is we've just started our focal therapy program on the MR-Linac, and we've actually mandated MRI and PET scan for follow-up. In fact, I'm quite bullish on a PET scan, and I actually wonder whether an MRI scan is necessary with a PET.
The PET comes back positive, and you wonder if the MRI is still necessary if the PET is positive.
Or just follow-up. It should be negative, I guess.
Okay, so I think the same rules apply whether you have focal, you have active surveillance, or you have radical prostatectomy. So local staging or local tumor detection, MRI is definitely superior to PET. PET has its limitations, but of course distant metastasis, PET wins. So I think you need both depending on the clinical situation that you are in. If you are looking for local recurrence within the gland, I don't think the PET at this point in time is able to replace the MRI right now. I don't think PET MRI works to the level that a multiparametric MRI works as well.
Okay. It's just that if we do have rising PSAs post radiotherapy or radical radiotherapy for our prostate cancers, I must admit PET scans are usually the go-to modality at the moment, for us anyway. And then an MRI scan if we find a hotspot, for example. Just wondering.
Yeah, so MRI will always be better for the local gland to look for local recurrence if you want to biopsy it. So MR is definitely the investigation of choice to look at the gland itself.
I think there are a couple of things about the PET scan. When we review the PET scan and we see that it lights up very brightly on the actual imaging itself, that can actually be turned up and down by the radiologist. That doesn't indicate anything. They can make it as bright as you want it to be. So I do think that for local control, I agree with Dr. Lau that absolutely a multiparametric MRIs, is paramount. We do have some patients where we've had PSMA PET MRIs. At our institution, we are able to fuse that image, but for most institutions, I don't think. So even at our institution, I don't think you can fuse a PSMA PET CT. So in that instance, if you're going to do a targeted biopsy, you're going to need the MRI regardless.
Okay, excellent. Thank you.
One more thing that I would like to add to that, I think, is many times the patients will have a urethral diverticulum, and you might just get concentration of PSMA in that, and it's going to become very difficult to assess if there's residual tumor right at that site on PET. Thank you so much. With this, we'll end the session. Thank you again to all the speakers for a tremendous job. Thank you.
Morning, everyone. For our next session, we have a crossfire debate on a highly contentious topic on whether biopsies are necessary following focal therapy. It's my distinct pleasure to introduce my co-moderator, Dr. Polasic. He actually needs no introduction. He is the founder and immediate past president of the Focal Therapy Society. He's also professor of urology and radiology at Duke. He was my fellowship director and Jack's fellowship director at Duke. With us today, we're going to introduce the first speaker. The first speaker is Dr. Andrea Brew from the University of Southern California. He is currently serving as the Associate Professor of Clinical Urology and Radiology at USC in LA. He holds the esteemed position of Director of Image-Guided Surgery, Focal Therapy, and Artificial Intelligence for Prostate Cancer. Please take it away, Dr. Brew.
Thank you so much for the introduction, for the kind introduction. Thank you for the invitation. It's a pleasure, honor to be here. And this is a hot topic, and we may have some good discussion afterwards. So my job is to defend ES, and not only that I would like to defend ES, is like I believe that ES, that biopsy is necessary, and that's what I would like to show. So these are my disclosures. How we follow up a focal therapy for prostate cancer. PSA, MRI, contrast ultrasound, multiparametric ultrasound, multiparametric MRI, PET PSMA is coming up in prostate biopsy. This is pretty much what we do overall. Actually, PSMA is coming. How about start with PSA? We know that when we do focal therapy, the PSA should drop approximately 70%. There are some series that say 50, some series that say 70. Overall, what we use is 70%, and the PSA should stay at that level. However, as you can see, even if the PSA is low, some patients still have recurrence. We know that the PSA reduction correlates with outcomes. We correlate with the prognosis of the patient. However, we do not know what is the cutoff for this PSA. We know the velocity, it's good, but we don't know the cutoff. There is no biochemical failure definition. We use other definitions from radiation oncology, but we don't have something for focal therapy itself. There are some manuscripts that try to do this, find a cutoff PSA definition for biochemical recurrence. Having said that, this manuscript itself, many of these patients that are there did not have biopsy. So how can you define the cutoff, the biochemical definition, if your biopsy itself was not done? So to summarize, PSA is not cancer specific. It should decrease 70%. It depends on the amount of the ablation. It depends on the initial PSA. It depends on if the PSA is stable or not. PSA bouncing it happens with focal therapy as well. The value and kinetics are important. PSA density, according to the ablation of volume on follow-up, should be something to be more investigated. There are some work done there. It correlates with retreatment, but we have no definition, right? So same PSA issue for diagnosis and follow-up. How about MRI? MRI is the main thing for a modality for surveillance after focal therapy. Is shown in this manuscript, this is a consensus, MRI should be done routinely, right? I agree with that. The problem with MRI is that MRI has several and severe limitations, including quality and reproducibility. And this is critical. Now, this is a patient that came to me for biopsy from an MRI done outside with this report saying there was a Paredes 5 lesion. I said, wow, okay, where is this lesion? I don't see it. I asked for my radiologist to review. The radiologist did not find the lesion. From Paredes 5 to no lesion. And we know that there are a lot of limitations with radiologists. Training expertise, workload, exhaustion, burnout, search satisfaction, reading and report, dictating, so on and so forth. They are humans. Probably AI will overcome some of this, but currently that's the standard of care. That's what we have. Inter-observer variability amongst experts with MRI is terrible. The best among experts is 50%. You flip a coin and then you say, yeah, this is 50, this is Paredes 5, this is Paredes 1. Not only this, the Paredes system, which is excellent, needs a lot of improvement, of course. However, it's done for primary setting. There is no consensus. There is no, this is lack of consensus on how to read MRIs after focal therapy. Now let's go to the real data. Can we do active surveillance only with MRI? Then there's this manuscript, patients who underwent mapping biopsy, transperitoneal mapping biopsy, 30, 50 cores, underwent surveillance and MRI. They repeat the same biopsy 3 years later. They said MRI cannot predict cancer progression. Similar data from MSK, they say, yep, MRI is helpful to identify, but MRI cannot rule out progression of patients on surveillance. Someone may say, oh no, but if the lesion is not visible, then it may not be important. This is highly debatable, highly debatable. The data that support this is minimal. The manuscripts that are there, 16 patients, 20 patients, 24 patients, anecdotal. there are some series saying that the MRI overcome the PSA. I overall would agree with that, an early MRI, although MRI is expensive. Data from focal therapy. This group shown these results of the MRI, negative predictive value of 96%. So if you want to avoid biopsy by using MRI, you look the negative predictive value. If you want to identify cancer, you look for the sensitivity. So negative predictive value, 96%. This is as good as it gets on the primary setting. This is excellent. This is a very highly specialized group. My question is, can this be reproduced by others? The answer is no. Here we go. This group, 75 patients who underwent HIFU, MRI, mapping biopsy, and then they repeat everything on the follow-up, MRI and biopsy. The results of the MRI. Sensitivity, 14%. MRI was able to identify only 4 out of 28 clinically significant cancers. And these are visible. These are real cancer. Now, they were visible before, I mean. Afterwards, they are not visible. That's the problem. Our series from HIFU, 100 patients, sensitivity of the MRI, 44%, negative predictive value, 74. IRE, so we talk about HIFU, IRE, and keep going. IRE, similar thing. Negative predictive value is 85%. And sensitivity and so on, poor. Keep going. This is a manuscript from in Ryu, in major institution, one of the best in the US. Look at the MRI performance. It looks like a joke. When the MRI sees something, the biopsy doesn't see. When the biopsy sees, the MRI doesn't do. It's like, it's completely chaotic. There is no correlation at all. The MRI cannot predict any of this recurrence. Now, having said all of that, there are some work being done on this, and we should take it serious. Group from London, from UCL, group from Imperial College. These are very nice putting together, and we as a society, we as urologists should embrace this, should keep doing MRIs and doing biopsies to validate this and create data. Then 5, 10 years from now, we can come here and they say, hey, now there are some patients or there are a group of patients we don't need biopsy.
Dr. Brew, unfortunately, we're running out of
You're
time.
good?
Could you please finish up?
Okay, so just to summarize, focal therapy with MRI. This MRI is not specific, anatomy distortion, then there is a lot of issues with MRIs. PET PSMA, we have no data on PET PSMA. It's just coming. There is one manuscript with 10 patients, and all the issues are already discussed. I just want to bring one more thing for biopsy. Look at this. 54% of patients who underwent salvage prostatectomy post-focal therapy have T3 disease. Another series, 71% with T3 disease and 16% with positive nodes. Another series from USC, same thing, 76% of T3 disease and 16% of positive nodes. If we don't do biopsies, we will detect these cancers late. All these patients will pass the curative window. And that's why biopsy should be performed for all the patients. Thank you.
Next up, for no biopsy, we have Dr. Peter Chiu from the Chinese University of Hong Kong. Dr. Peter Chiu did a PhD in prostate cancer in the Netherlands. He's currently the president of the Hong Kong Urological Association. And please take it away.
Thank you very much. So thanks again for TS and the organization and Jack and for the invitation. And again, I feel like I shouldn't be called Peter. I should be called like David because he's Goliath. So yeah. So and the first thing, like, because I'm actually defending like should not do biopsy. And but the first disclaimer is that I actually do biopsy. So for most of my patients, but there, you know, this is a wonderful exercise because when I try my best to look for the evidence, data to support why I should not do a biopsy, it's actually a very interesting exercise. Okay, so in short, in one slide. Now, the debate here is biopsies are not necessary for everyone after focal therapy. I'm not saying that like it should not be done for everyone. It should not be done. It should not be mandatory for every single man after focal therapy. And biopsies are definitely needed when there's a suspicion. Now, there are various reasons, but which I will gonna support that one by one afterwards. So first is now, Andre have actually talked about a lot of like previous poor MRI evidence in predicting, but now we're actually having more like standardized methods like MRI with new standardized post-focal therapy reporting. We actually have PSA derivatives, although I understand that like PSA may not be the very accurate, may not be always reliable, but there are actually data showing that like in some patients like they're actually the recurrence rate is really low. And again, is there any dire urgency to diagnose that grade group 1 disease or small volume 2 millimeter grade group 2 disease at 12 months? I'm not sure. And also the risk of prostate biopsy. Okay, so this is one of my case, one of my failure case, in fact, my first microwave in my series, which I regret doing that in that way. So pre-treatment, ICB grade group 2, left anterior obvious tumor. The MRI at 1 week showed that the ablation was really suboptimal. At the time, I really didn't know how the microwave works, and this patient suffered. Per protocol, 6-month biopsy showed grade group 1. This MRI, there's actually some residual, there's some recurrent disease like over there. There's actually a residual disease, not really recurrent disease. And for some reason, it's grade group 1, so kind of reobserved. But the PSA rise over 18 months from 2 to 6 to 8, and the patient wasn't very comfortable. We did another biopsy, still grade group 1, but then he felt like doing another ablation, so I did an ablation, and PSA dropped from 8 back to 2, and now it's just 4 years after the treatment, and there is no PSA rise from the 2. I did not do another biopsy at 4 years though. So in a way, MRI tells us, that there's a change in MRI, and we do diagnose cancer, which we could actually successfully retreat it with focal therapy. There are different recommendations now for the MRI, as mentioned by Dr. Law just now. I do not need to repeat the details, like a target, like consensus. They suggest a 5-point MRI score published very recently, dividing them into like 1, 2, 3, 4, 5. In short, the main thing about a DC is like whether it's non-suspicious, equivocal, or suspicious. And this is one of the examples, like the first row in that paper shows that like this is a score 5 out of 5 because both ADC, high B value, DWI, and DCE were suspicious, and biopsy was ICB grade group 3. The row below is a score 2 out of 5, which shows low suspicion, because only ADC and DWI was slightly abnormal, but the DC was, there's no contrast enhancement, and the biopsy was benign. The other thing which we discussed quite a lot just now was the PIFAP score, actually written by my good friend Francesco. And I agree that, when it's published, actually there's no data, and they are actually doing that, quite a lot of external validation. And in this is also like from 5 at 1, 2, 3, and if it's a 5 at PIFAP 3, we should do a biopsy. Right. So there's some validation, 2 papers which actually have been mentioned by Dr. Law. I'm not going to do that. But the NPV is actually pretty good. The specificity is pretty good. So I think it's actually quite useful. Not that it could exclude all the significant residual cancer, but it could, at a good negative predictive value. Now, how about the PSA PET scan? Now, I only have a very short time to look for it. I probably have missed some, but this is the paper which I see that is a pilot study on 14 patients, only 14 patients showing a PET study to look at the PET scan and the MRI. And it shows some encouraging results that the PET scan actually picks up all the residual significant cancers, but the MRI only 86%. So on the other hand, I mentioned that there are actually other things. I'm a strong believer of biomarkers because my PhD is also actually on biomarkers for prostate cancer diagnosis. So now, for example, in a very good series in UK reported by Stability 5 years ago, like actually the baseline Gleason score predicts recurrence. Now, if you have a 3+4 or 3+3 disease, for some reason you did the focal, you have a lower chance than a 4+3 to have a recurrence. And this actually would and in fact, when we look at the Kaplan-Meier curve, look at the retreatment rate, how often do you retreat, these patients within 1 year? And that tells you, of course, they may not have 100% biopsy, which may have to change the management. But, how often do you have a retreatment after you have successful focal therapy within 1 year? And there's evidence that like PSA velocity in biochemical recurrence-free patients after focal therapy, say the velocity is 0.15 versus 0.04, which is actually stable, actually predict biochemical recurrence. In PSA density, 0.16 versus 0.07. So if you have a very low PSA density, like around 0.07, after focal therapy, probably the risk of recurrence is actually very, very low. And there's external validation. Andre mentioned about the Huber criteria. And it was shown that at 5 years, additional treatment is only 89% if the criteria is positive, while it's only 26% that needs additional treatment at 5 years if it's suggests to be low risk. Conscious enhanced ultrasound intra-op, the value of intra-op CUS during focal therapy in predicting the 1 year recurrence. Independently, probably not very useful, but combining with the 1 year multiparametric MRI, it actually shows that it actually increased the AUC in predicting positive significant cancer on biopsy. And I cannot ignore this paper, which is actually very important because MRI visible and MRI invisible lesions actually carries very different prognosis. 3+3 disease, if it's MRI visible, is actually more aggressive. Invisible 3+4, which, as said, if after MRI there's nothing there, if it is a 3+4 on a biopsy, I believe the tumor volume is very small, and I believe the biological behavior is actually very different from the MRI visible 3+4 that we see and we biopsy. And again, this is not evidence-based. This is from a user experience. Like when you do a biopsy, it's like MRI negative. You do a saturation biopsy, and you should get some 2 course of 3+4, for example. How often do you get like 8 millimeters, 10 millimeters? You never. It's like 2 millimeters, 3+4. That is not seen on an MRI. And when we look at the PROTECT trial, 1/3 of them actually have grade group 2 disease, and even active monitoring actually have similar cancer-specific survival and overall survival, in this group of patients. So is there a dire urgency to treat these patients? Maybe not. And again, the focal therapy results are getting better and better with, along the way across different modalities, HIFU, cryo, IRE. The residual recurrence rates is like less than 20% compared with like 30-40% in the past. And looking at IRE data, 8.5%. If 8.5% at 1 year biopsy, which means you're doing 12 biopsies and just, okay, I know time's coming up, but is it ethical? Like if it is just 8.5%, 6% positive biopsy, and you biopsy in 100% of the patients, and also that in the sensitivity of in the PROMISE trial, 88% for 3+4, and we accept not doing biopsy in MRI negative patients. And why are we now rushing to biopsy after focal therapy? So in the end, who likes a biopsy? Hands up. Okay, no one. Okay, so there are a long list of complications which I don't need to tell you, but in fact, there is evidence that patients on active surveillance, for example, if you tell them they need to do regular biopsy, they actually refuse active surveillance, and this actually goes the same with focal therapy. So I'm sorry for the overrun, but I think a personalized approach should be taken instead of a kind of a routine, mandatory 1 year biopsy. So that's my take to it. Thank you very much.
I want to thank our 2 presenters. A lot of excellent points raised. I would say that we're in our 14th year of this meeting now, and we've been saying for many years that we collect PSA for research purposes, which I still believe is important, but we're not really any further along on PSA definitions after focal, 14 years into it. We've heard some of the pros and cons of MRI. The 96% NPV sounds very good, but a lot of these papers come from the primary setting, but we're looking at a post-ablation setting, and I think you lose a lot of that NPV and some uncertainty. And then finally, regarding biopsy, I think we'd like to, and I think where we're headed is we're trying not to do as many biopsies. Our patients don't want them as well. They're happy following by MRI alone, but it's kind of up to us to collect the data and make the scientific point that maybe they may not be needed or how often they may be needed, things like that. So very fascinating points. Wanted to thank everyone. Are there any burning comments from the audience?
Thanks, Tom. As a radiologist, just one comment. I think the ADMITech has taken this up as well to come up with a kind of, scoring system very similar to the way they had worked on the PIRADS for treatment-naive prostate. And once that comes out, I'm sure there are going to be many, many validation studies. And that will give the confidence to all of us. What is the true NPV if everyone kind of adopts such one scoring system? Thank you.
Yeah, it'd be great to have a MRI-only definition. That'd be wonderful. Patients would applaud that. They don't like being biopsied, but you got to wonder, on the one hand, we're finding stuff by biopsy. What do we do with it? And on the other hand, we're trying to decrease the morbidity of both surveillance and focal therapy.
Look, just real quick, I think most of the literature is really problematic. In almost every study that's shown, the only way you can talk about the performance of the MRI is you got to do a biopsy on everybody. And if you look at most of these studies, most of the patients haven't had a single post-op biopsy, yet alone, longitudinally. And I guess the thing is, if your MRI is really good post-ablation, you're not doing good ablation.
One final question for the audience. Who here does post-treatment biopsies routinely? Who here does not do post-treatment biopsies?
We are the radiation oncologists.
Thank you very much. This concludes this session.